Hello, everybody. Today we're going to provide a presentation on personality disorders. And today's presenters are Claire, Yelena, and myself. Continue, please. So on today's agenda, what we'll talk about is what are personality disorders. We'll do a brief portion where we kind of test your knowledge a little bit to see what you know about personality disorders. We'll provide our article, and then after that, we'll look at what's next. Continue.
Okay, what are personality disorders? Personality disorders are long-term patterns of behavior and inner experiences that differ significantly from what is expected. The pattern of experience and behavior begins by late adolescence or early adulthood and causes distress or problems in functioning. Without treatment, personality disorders can be long-lasting. Personality disorders affect at least two of these areas: way of thinking about oneself and others, way of responding emotionally, way of relating to other people, and way of controlling one's behavior. There are, oops, I jumped. There are different types of personality disorders, and I try to summarize them here. So I'll read some of them. For example, antisocial personality disorder is a pattern of disregarding or violating the rights of others. An affected person may not conform to social norms, may repeatedly lie or deceive others, or may act impulsively. Paranoid personality disorder, a pattern of being suspicious of others and seeing them as mean or spiteful. Um, Dependent personality disorder, a pattern of needing to be taken care of and submissive and clingy behavior. Avoidant personality disorder, a pattern of extreme shyness, feelings of inadequacy, and extreme sensitivity to criticism. Narcissistic personality disorder, a pattern of need for admiration and a lack of empathy for others. You could further read about those disorders in our PowerPoint presentation that we save. And now let's watch a short movie that explains more about those disorders.
All right, in this video, we are going to talk about some personality disorders and talk about nursing care of some of these personality disorders. So there are 10 that I would be familiar with, and I'm going to go over just some key points with each one. So the first one is paranoid. So it's kind of like what it sounds. A person who is paranoid will distrust and be suspicious of others. Then the second one I would know is schizoid. With schizoid, the individual will exhibit emotional detachment and indifference to others. Okay, so they don't really care and they kind of do their own thing. Then with schizotypal, someone once told me that Willy Wonka has schizotypal personality disorder. So some symptoms with this personality disorder include magical thinking, odd beliefs, and perceptual distortions. Kind of lines up with the Willy Wonka personality. Then we have antisocial personality disorder. This is not what it sounds like, okay? So it's super important to know. Antisocial sounds like somebody who just wants to like chill out and Netflix in their room and not be social with others, but that is not what this personality disorder is about. So someone with antisocial personality disorder will exploit, manipulate, and deceive others, okay? They can be very verbally charming, but they fail to accept personal responsibility for their actions, okay? Then we have borderline personality disorder. So with borderline personality disorder, the patient will exhibit what we call splitting behavior. So with splitting behavior, people are either all good or all bad. There's no in between. So one day the patient may be all about this nurse and think this nurse is amazing, but maybe this nurse said or did something they didn't like, and all of a sudden they hate her and she's the worst nurse ever. And that's kind of how they operate. They can be very impulsive And then the other really important thing I would remember about borderline personality disorder is that these individuals may be at high risk for self-injury and or suicide. So definitely keep that in mind. Okay, the next one is histrionic personality disorder. With histrionic personality disorder, these individuals are attention seeking, they're seductive, and they can be very flirtatious. And then we have a narcissistic personality disorder. These people will be arrogant, they have a need for constant admiration, and they really lack empathy towards others. Then we have an avoidant personality disorder. This is a person who would avoid social situations and interpersonal contact due to extreme fear of abandonment or of rejection, okay? Because they're scared of being rejected, they're not even gonna put themselves out there and try to talk with anybody, and they're just basically going to avoid those social situations. Then you have a dependent personality disorder. This is a person who has an extreme dependency in a close relationship, and they need like excessive input from others to make any kind of decision, okay? And then finally, we have an obsessive compulsive personality disorder. This is someone who really strives to achieve perfection, order, and control, and this can result in the patient not completing any tasks because they're so focused on achieving perfection. All right, so in terms of nursing care, you're going to want to provide safety for patients who are at high risk for self-injury or violence. So for example, with the borderline personality disorder, they're at high risk for self-injury or suicide. So you're definitely gonna wanna provide for safety for them. You also want to provide limits and consistency for many of these personality disorders. So in particular, borderline and that antisocial personality disorder. Remember, that's someone who's manipulating and deceiving others. So you're gonna really wanna set limits. And then you want to provide assertiveness training for dependent or histrionic personality disorders. And you want to respect the need for patients with either schizoid or schizotypal personality disorders to isolate themselves. So again, that schizoid personality type is someone who's kind of indifferent and emotionally detached. And if they want to just do their own thing, they're not hurting other people, then you should let them isolate themselves. There's nothing wrong with that.
What causes personality disorders? Research suggests that genetics, abuse, and other factors contribute to the development of personality disorders. In the past, some believed that people with personality disorders were lazy or even evil, but new research has begun to explore such potential causes as genetics, parenting, and peer influence. Now that you have heard and learned about the personality disorders, let's check how well we can distinguish them. Let's read a statement and try to figure out what disorder the statement could be best applied to. So, ready? Let's go. Others tell me that I need to rely less on others for reassurance. What is it? Dependent disorder, antisocial, schizoid, or narcissistic? And it is, oops, sorry about this. It is dependent. I do not understand why people would ever want to go to Paris. I'd rather sit at home. What do you think? Right, this is a schizoid disorder. My boss told me I was late at work, so I picked up a pair of scissors off the desk and threw them at him. So this would be antisocial or borderline disorder. I tried to play Monopoly with my family, but I spent hours reading the rules to make sure we were playing correctly. This would be obsessive compulsive disorder. My cats keep bad spirits out of my home. This would be schizotypal disorder. My neighbor is looking at my house. He thinks of breaking in. This would be paranoid disorder. I enjoy being the center of attention. This is histrionic or narcissistic disorder. I never feel happy or sad or angry, just numb. This would be schizoid. Could be also antisocial disorder. After my therapist rescheduled my appointment, I made several cuts across my arm. This would be borderline disorder.
Okay, so the main concern of the article that we're presenting today is evidence-based treatment for patients suffering from a personality disorder, but it's often only limited or available to a limited extent. So therefore, most patients receive care that is not specialized. So this article describes the background, rationale, and design of something called the Guideline Informed Treatment for Personality Disorders, also known as GIT-PD initiative. So this framework integrates scientific knowledge, expertise from professionals, and experiences from patients to design a good practice that is based on common factors of already known treatments. So it offers a basic framework that includes a structured clinical pathway, which I will present in a future slide. Also includes interventions that are focused on common factors, as well as team and organizational strategies, and is based on common features of evidence-based treatment and generic competencies for professionals. So for countries with an interest in improving their healthcare system, could serve as a template that requires only limited resources, because this study did take place in the Netherlands. So next, please. So preliminary data shows that despite the differences in various theoretical backgrounds and approach, all specialist psychotherapy programs for personality disorder seem to be relatively equally effective for treatment, and that could indicate the importance of certain common features across the evidence-based approaches for personality disorders as opposed to their specific features. So previous research has identified 5 features that could explain the similar effects. So those are clearly structured treatment framework, an active position of the therapist, a focus on the therapist-patient relationship, the use of interventions that are aimed at exploring the relationship between emotions, thoughts, and behavior, and also interventions to support motivations for change. Simplifying treatment principles can improve the ease of application and also of adherence. These general principles can be applied more easily across different types of personality disorders, while as opposed to specialist theory-driven models, which are often focused more on specific types of personality disorders. So, instead of following the, sometimes cumbersome and, costly process of implementing the evidence-based specialist programs, the general quality of the personality disorder treatment may be improved by this level of care and existing services in accordance with the common features approach. So the development of the GIT-PD method, starting off with clinical pathways, meaning that treatment should be phased with a specific target in mind for each phase. So phase 1 is going to include assessment, discussion of the core issues, and then also very careful treatment planning that is discussed, of course, by both the client and the therapist. So that's phase 1. Phase 2 is the treatment phase, and that involves anticipating any crises that may happen, psychoeducation about the disorder, and also the implementation of the treatment planning that was developed in phase 1. So in order to support that implementation, there is online support. There is a website for GIT-PD that contains general information as well as some external resources. There is also a training course that offers active training on basic interventions and as well as treatments on supervisions of this intervention. A template for managerial expectations, which is a support tool which offers steps for making implementation of this intervention successful, as well as quality maintenance, meaning there's audits every 2 years to assess the quality of service, and that those are based on the criteria for the GIT-PD. And as I stated before, this is the clinical pathway. So GIT-PD stresses that that the treatment should be structured. So it should be phased with specific targets, and specific targets for each phase should be identified. So this is the clinical pathway. So you have the primary evaluation, which includes the formulating the case. So that would be the interview with the patient, the family, psychiatric evaluation, and other assessments or measurements, as well as shared decision-making, which is the treatment planning aspect. And then moving on to the treatment phase, that includes the psychoeducation about the particular disorder, also anticipation of any type of crises that may occur, and motivation and engagement of the client, and then execution of the selected treatment interventions. And so then that will lead to termination, which is anticipation of any symptoms of relapse, may include booster sessions, generalization outside of therapy, and social rehabilitation.
All right, so as we've kind of gone over the GIT-PD, just a couple of things to kind of take note of is that the framework is designed to be implemented over time, and it's also provided to kind of help provide some, good treatment, type of practices for patients that are dealing with personality disorder. And so something to note is that since the introduction of the GIT-PD initiative, there's a tendency to shift towards specialist psychotherapeutic centers in the Netherlands using GIT-PD as a basic treatment program for the majority of their patients, while serving their specialists and programs for more complex patients who often have had an extended history of treatment failures. Next, please. Some of the limitations of the implementation of GIT-PD is that although there are inter-institutional audits that are conducted, data is not collected in a way that allows monitoring on the impact of the actual program itself. So GIT-PD actually lacks scientific evaluation, evidence of the effectiveness of the clinical practice itself. Yet just keep in mind that again, that GITPD has actually been implemented in other countries as well, as a form of practice to assist patients that are suffering from personality disorder. Next. All right, so when we talk about the development of GITPD, we look at some of the treatment manuals. We focus on subgroups. Um, Principles were discussed and matched with literature searches by a focus group of 15 to 20 professionals who actually created this manual. And then one of the other things that we want to kind of emphasize is that empathy problems affecting the therapeutic relationship and potentially making treatment less effective. Next, please. All right, so where do we go from here? The GITPD was initiated in the Netherlands to, again, kind of get after a process within clinics and facilities to get after being able to treat uh, multiple PD patients. And so this initiative was initiated in 2012, starting with 8 mental health care centers. And so 8 years from that point, there's now 20 large, 20 large Dutch healthcare institutions that participate in the GIT PD program. And so that kind of lets you know kind of the gain that the initiative has gotten since 2012. It's become widespread and actually it's become well known, especially in the Netherlands, and it's also spreading, worldwide as well. Next, please. And so what we've provided to you here is just a little bit more information. If you want to kind of go to the APA site, or if you want to kind of take a look at the document that we provided to you, we provided to you the DOI so that you can kind of take a look at that as well. And if there's any other questions that you may have, then we'll gladly entertain any questions as you kind of look down through the site and as you kind of make some responses to our presentation. But again, we greatly appreciate any questions you may have about the GITPD. Again, this is something that we looked at as a clinical implementation where you can kind of help assist personnel with personality disorder, and you can help provide assistance to a multiple amount of people that are suffering from PD and provide the most care possible. So again, we want to say kind of thank you for listening, and we greatly appreciate everything. You all have a good night. Thanks. If you looked at our initial video, we talked about a clinical approach to providing and servicing clients and patients that have personality disorder when you're in a facility where there's a short staff of counselors and psychologists. There is a methodology that's out there, and I think that article that we provided and the briefing that we provided gave some good information on that. So now what we want to do is kind of go and take a look at a specific theory of DBT, or to kind of treat patients with personality disorder in a residential setting. And so the name of this article is called Treatment Effects Following Residential DBT for Adolescents with Borderline Personality Disorder. What we'll do is we're going to go over some goals of the study, methodology. We're going to review DBT. And if you want to take a look at the theories of counseling and psychotherapy and integrative approach. And then once we do that, we're going to take a look at some results and a discussion, some limitations and clinical implications, and then we'll give a reference and then we'll be done. BPD, which is, it's characterized by repetitive, suicidal, and non-suicidal self-injurious behaviors extreme emotion and behavioral dysregulation and disruptions in interpersonal relationships. And so what the articles talks about is that DBT has been used and it's empirically supported for treatment within adults, but there was some controversy on whether or not, number one, adolescents should be diagnosed with personality disorder, and then the second thing is like how to provide treatment. And so what this article did is that they wanted to, because there was a lack of research, they wanted to document and record a study on DBT provided for patients between the ages of 13 and 20. So the goal was to test DBT treatment for 1 month as a aggressive approach to assist. And then the other thing is to also determine whether sexual or physical abuse and the client's history affected the treatment outcome. And so let's take a look here. So the procedures was that they utilized a couple of interviews to determine where the person was as far as their severity of personality disorder. Once they recorded where the patient was, 30 days later, they came back and take a look and see where the patient is. They utilize the treatment approach from Linehan's and Rathers and Miller's manuals on DBT. The participants were 53 female patients between 13 and 20. And then I've got the ethnic breakdown if you want to take a look at that. All right, so for the measures, the assessment team were bachelor level and graduate level and postdoctorate personnel that conducted the initial assessment. To the symptoms and severity assessments, there were various tools that were used, and I have these tools here. We've talked about some of these in some of our classes, so some of them may be familiar and some may not. All right, so let's go ahead before we get into what the results were for this. Let's go ahead and talk about DBT. So DBT is a principle-driven treatment program, and it looks at validation and acceptance strategies and incorporates those things into the overall program. And so DBT targets certain behaviors. If you take a look at this portion here in the very middle of the slide, you'll see where it has a climbing effect. So first, DBT looks at, let's try to work on what the suicide behaviors are and try to reduce that. Now, whatever the non-suicidal self-entry issues are, this is kind of the phase 2. Let's look at that. And then let's look at any treatment interfering behaviors that may be preventing treatment. And then last, let's start to look at the things that will help increase this person's quality of life. And so those are kind of the 4 phases. And there are 4 core modules within DBT, which is mindfulness, emotion regulation, distress tolerance, interpersonal effectiveness. All right, so now what was the results of this particular study? Comorbidity is high among groups of folks that are experiencing personality disorder, with major depressive disorder being the most common, and then anxiety-related disorders being the next. And so 1 month treatment reduced a lot of the BPD and MDD related symptoms, but it had little effects on their anxiety symptoms. Let's go down just a little bit further here. And then those who had sexual or physical abuse scored higher symptom severity at admission. However, based on the results, it did not have any effect on the actual treatment. All right. So what are the limitations? The limitations to this particular study was that there was no other group that you could compare the outcomes with. The second thing is that there was pharmacotherapy that was used in this particular study, and so we can't say that it was completely DBT. But the good thing is, if you wanted to utilize this particular document as a means to support pharmacotherapy in addition to DBT, then you can utilize this as a means to show that there is some effectiveness. All right, and then the last thing here that I wanted to pull up is that 1 month residential treatment is good for helping to reduce some of those BPD symptoms. However, one of the things that we look at is that it didn't reduce anxiety. All right, so here are the references, and then there's one other thing that I wanted to add in this as I kind of go back here to limitations and implications, the sample size was primarily white females. As you saw, it was 41 white females from families that made about $100,000 or more. And so that's just one of the things to kind of think about if you utilize this particular document as a means to support a treatment plan. I hope you all have enjoyed both of our presentations, as we kind of enjoyed being able to get it out there to you. Thanks, and have a great day.